right? 9, 8, 7, 7, 8. I believe we're at the 7, 8 disc. Everybody in agreement? Excellent. Go back to let's just check one more time. Let's just go down to 12. Just go back down to 12. And let's just make sure. I want to see that 12 rib. Not too far south, but just take us down a little bit. And shot. 7, 8. Keep going. 8, 9, 10, 11, 12. And a little bit more. 8, 9, 10, 11, 12. What am I counting, folks? I'm counting the pedicles. What is a pedicle? Take a shot. Right there in front of this thing is the pedicle. Let me show shot. Yeah, okay, that's good. Perfect. Show them another pedicle down below. Yeah, so that would be 9 pedicle, then go down to the next one, 10 pedicle, go down to the next one, 11 pedicle, go down to the next one, 12 pedicle. Show them the rib attaching to the pedicle there. Yeah, it really doesn't attach to the pedicle, it just looks like it on AP view, but that's the T12 rib because you can look below that and there is no more rib, and there's just a transverse process. So that transverse process is just the lumbar spine, basically. So that's L1. So we know we can count up from T12 by counting the ribs and the pedicles, and we know we're at T7-8. All right, back to a lateral view at T7-8. Blood pressure good? Let's see if we can bring it down a little bit. So everything is going perfect. Are you comfortable? Huh? All right. So you can see our patient is young, not like a kid or anything, but he's still young. Can you underpenetrate that a little because you're a little bit overpenetrated? He is young, but he has some pretty significant disc disease. He has some pretty significant disc disease, especially on the right side of the spine. Okay, we can see those bone spurs. All right, so, all right. You comfy? All right. Shot, you're doing fine. Just relax. Shot. Shot. All right, so my patient here, when I talked to him on the video conference, he's from California, right? But you're going to Australia. So he's been having thoracic. How long have you had thoracic pain? Give me the number of years. 4 years. You never had a problem before that? So 4 years ago, he got pain here and around here. And this is by far the worst pain for him. And, you know, did you do shots? Epidurals. So he tried shots, and they gave you temporary relief? Yeah, temporary relief. But it kept coming back, right? So he decided he wanted to get it fixed. The problem is there's very few doctors in the world that can even fix a thoracic disc herniation. And we are the only ones in the world that do endoscopic transforaminal thoracic disc herniation repair. Are you comfy? Yes. Is that a yes? Yes? As much as you can be, right? For me poking on you. Shot, where do you feel that? Huh? Okay. Where'd you feel that? In the spine? Yeah. All right. So our patient is completely awake. And the reason is he needs to help me. I'm almost ready to put him to sleep, though. That's the good news. Sean, you can see we're closing down on the 7-8 disc right in the back. We're in the foramen. Let's get an AP view just to make sure everything looks good. We know we've checked the proper we've localized the proper level. We are at the proper level, T7, T8. Everyone in agreement? So now that we know we've selected the proper level, now we can go in and repair it. So you can see we're right almost at the medial border of the pedicle. We're kind of mid-pedicular line. And that's the perfect place to be. So we're about to enter the T7-8 disc. So things are gonna move pretty quick now. So everything is going well. We're well away from the lung fields. Are you comfy? All right, just about ready to put you to sleep in just a few minutes. And I'm just moving very nice and slow and carefully. About to enter the disc. You're going to love watching this, I think, when you're done. Blood pressure is good. See if we can bring it down a little bit. Are you comfy, sir? Yeah? All right. We're in. We did it. You did it. The hardest part of the surgery done, okay? All right. I'm just going to give you a minute. Did you have any last questions before we put you to sleep? All right, so here is the disc right here. I just drew a circle for you. And this is the T7-8 disc. And let's verify that one more time with an AP fluoro. And then we'll come back. Now we're going to do a discogram because I need to put the dye that I need, the indigo carmine dye, inside. It's a 10% solution, if you know what that means. Relax. Beautiful. So we're in that, there you see 12, 11, 10, 9, 8, 7. So go up and show them 8, 7. Go up about 2 inches and show them, yeah, that's the 12 pedicle we have the arrow on so you can see. So there it is, 12, 11, 10, 9, 8, 7. We are in the 7-8 disc. Very happy? Not yet. All right, you can go back to a lateral view. Are you comfy? Just give me a minute. All right. Now, 4 years you had that pain, right? Okay. Was that the pain you feel normally? How bad is that on a scale of 1 to 10? What's the highest it went? I can't hear you. I want one number. What's the highest it went, scale of 1 to 10? That's all I needed to know. And it's where you typically get your pain, right? Congratulations, sir. We have identified the source of your pain for the thoracic pain. It's a 10/10, and it's a tear at T7-8. You're lucky your radiologist found that, because even I had a hard time seeing it on the MRI, but it's definitely there. And you can see the dye leaking out through the tear and going up and down your spine, your spinal canal in front of the spinal cord. But you can see the herniation. Show them the herniation, right where yep. Kind of circle it for everybody. That's it. It's incredible. That tiny little herniation. Almost missed on an MRI. Source of his pain, and it's going to be gone after the surgery. You get to go to sleep now. When you wake up, your surgery will be over, and you'll be very thankful it was done. Count out loud in Australian for me. He's going to Australia. He's having his surgery done. He's going to go home in California, and then he's going to leave for Australia. He's becoming an Aussie. He's following the Aussie coal, you know, the coal that the Chinese won't buy anymore. You all hear about that? Yeah. China is going into a massive economic downward spiral because they have not enough energy to have electricity to pay for, well, actually to produce electricity for their factories and their civilian population. It's sad. And so the factories are shutting down, and it's winter time, so it's going to get cold. They don't have enough coal. And they're fighting with Australia, and Australia is pissed, and China's pissed, and China doesn't want to take the Australian coal. But I think this morning in the news they're going to accept the Australian coal. Yeah, that's what I heard. They're allowing the ships from Australia filled with coal to come over to China, and they're going to use that coal. You know, it's better for the people. I didn't hear what he said. New development. Yeah, it's a new development as of this morning. All right, count out loud from 1 to 100 for me. Our anesthesiologist will put you to sleep. Everything okay? You got good flow? Huh?
I'm just giving him meds.
Yeah, but you got good IV flow. Everything's good? Yeah. All right, so as our patient goes to sleep, we're going to proceed with getting this needle out. Everything is going really well for him. Shot. I want to make sure the guide wire is in good position. It is. It's inside the T7-8 disc. You're looking at a side view shot. And this side view, we call it a lateral view. Lateral is the medical term. Lateral. So we have a lateral view of T7-8, and that weird tube right there, by the way, just so you know, is just this suction tube. Go ahead and take another picture. You can see it's gone. We've explanted it. It's a little bit of OR humor. Anyway, we lost maybe a drop of blood for the surgery. This surgery, so let me tell you, thoracic disc herniations are taboo in the spine world. No one touches them because they're scared to death of spinal cord damage, CSF leak. It's no man's land and no woman's land. I don't mean to be sexist, trust me. The reason is there are ribs here that block access to the disc. And the only way to get to the disc to fix it has been to do a fusion of the disc by cleaning the disc out, put a cage, screws and rods in the back. That's all we've been able to do all these years. So no spine surgeon in their right mind wants to do that for pain. So these patients are blown off for years by doctors. They're told there's nothing that can be done. You know, go do an epidural, go do a facet block, do some physical therapy, do chiropractic. They do all of that and they can't get better. This patient is a professional therapist. Okay, they're a sports therapist. And they know all the therapy modalities. They've tried them all. And yet they're here having the Deuk laser disc repair because they know nothing else has worked. So thoracic discs have been fixed traditionally with massive surgeries where the ribs are removed, the head of the rib is removed, and getting to the disc is a bloody mess. It's very dangerous, has to be done in the hospital, and the patients stay in the intensive care unit for maybe a week or two afterwards. That's how dangerous the surgery was. And then a surgeon named Curtis Dickman at the Barrow Neurological Institute developed a transthoracic endoscopic procedure. He would come from over here, go between the ribs, and put a scope in and, you know, next to the heart and lungs. I mean, dangerous shit. And then came Dr. Deukmedjian and did the first posterior transforaminal disc repair at Duke Spine Institute about 2 years ago. And this will be our 12th case, and every single patient we've done is at 100% elimination of their pain. Gone. All right, he's a little too light. Maybe, I don't know, but I just made an incision. He's moving a little bit. I mean, I numb this area up. So let's just keep an eye on it for a moment. You don't have to give him more sedation. I don't know if he's coughing or just responding. I'm going to give a little bit more numbing medicine. So you're happy? Blood pressure looks good. So he must be asleep. This is just some more numbing medicine just in case he's feeling it. Yeah, he's definitely feeling something, but that's okay. There's definitely lidocaine Arcane, right? It's funny, huh? We can't buy any drugs from China, but the pharmaceutical companies can, and then sell them here to us at higher prices. So stupid.
The biggest purchaser is the Mexican drug cartel.
The Mexican what?
Drug cartel.
Oh, really? Of those drugs from China? Yeah, fentanyl? Yeah. Right? I mean, fentanyl is like dirt cheap coming in from Mexico. It's killing people left and right.
Yep.
People addicted to heroin.
4,000 Narcan administrations in San Francisco alone last year.
4,000 Narcan administrations in San Francisco alone. That's shameful. So what are we talking about? We're having a side discussion about how so many people in America are addicted to narcotic pain medications. And why is that? You want to know why? See this patient right here? If I couldn't fix his thoracic pain, guess what he would be? He would be addicted to pain meds just like everybody else. And shame on us as doctors, shame on the insurance companies, shame on the government for allowing this to happen, to be honest. We can fix pain now. And that's what we're doing right here, right now with this patient. So I'm not going to say anything about their history of pain pill use, but I can tell you virtually every patient we treat here at Deuk Spine for spine pain, back pain, neck pain, thoracic pain, they all take pain meds. And when they're done with their surgery, they don't take narcotics. It's quite incredible. So we are just to the side of the spinal cord right now. We're on the right side, and I'm coming down onto the herniation. I can actually feel it with the tip. Shot. And remember, the tip of my dilator is pushing things around, aside. It doesn't cut anything. That's one of the beauties of this procedure, is we can fix things without cutting by just displacing. Of course, the laser itself is going to cut the annular tear and repair it, but right now I'm just displacing. Displacement means to move aside. Starting to get into the disc at T7-8. This is where his pain is. I just confirmed that his back pain is coming from here by doing a discogram. Okay? A very elegant procedure that's designed to do two things. One, it shows us the anatomy of the inside of the disc and the annulus, and you can clearly see there's a tear and the dye leaked out backwards through the tear. Second of all, it allows us to determine if the patient's pain is coming from that disc, in which indeed it was. Okay, I am now embedded in the disc, and I think it's safe to remove my guide wire and to advance the dilator through the tear into the disc. And that's what I'm doing. Shot. Now, sometimes the amount of inflammation in the disc is so severe that the patient actually will push the dilator out. All right, we're going to do the whole surgery, folks, through this tiny little tube. Diego, why don't you show our audience the Deuk laser disc repair video on how we do a posterior lumbar. It would be the lumbar one, not the cervical one. How we go in through the back, transforaminal. You're watching the first place in the world to do this. And again, we did this 2 years ago on our first patient. We've done, this is number 12, I believe, and we've had 100% pain relief in that area on every single one of these patients. Any questions from our audience?
No questions, sir, but we do have someone who wrote in all caps that they have that problem too.
Yeah. Yeah, I know. Painful thoracic disc herniations are not common. They represent about 2% of all painful disc herniations, maybe 2 to 3%. But those are real. Those people are suffering, and we now have a way to fix it.
We also have another comment that said that they had their T4-5 done by Dr. Deuk. And
oh, wow.
Yeah.
Okay. So we have one of my patients who did surgery here. That's amazing. They're watching this surgery. Is that right? Am I understanding that correctly?
Yes, yes. They say thank you and that you got rid of her horrible pain.
Oh, thank you. I'm so happy for you. And yeah, that's great news. So wow, that's a true treat for me to hear from one of my former patients right here during thoracic disc surgery on another person. So thank you for sharing your experience. That means a lot. Okay, we're driving down this tube into the spine. Shot. And let's see here.
Muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. To accommodate the fusion hardware, a large bone grabber is used to perform a laminectomy by removing bone from the spine. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, The laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large pedicle screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery.
3, 2, 1.
All right, well, can you see the surgical field here? Let's turn the light on for
Yes.
a minute, just so everybody can see. So we are on the right side and we're going into the disc. We're passing through skin and fascia and muscle. Nothing dangerous here, and we've got our scope. We're ready to get started. Okay, you turn the light off and let's get going. We're going to dive down this rabbit hole and see what's there. There will be an annular tear, for sure, and there's going to be a herniation. It won't be a big one, it'll be a small one. So this should be a relatively quick procedure. We're going to improve the focus a little bit, because the focus is terrible. That's on my end. Thank you very much, Jordan. Bam. Already some pieces of herniation. I'm going to go grab them out. So you've watched the video on how annular tears become painful. And what's the secret? It's inflammation. They cause inflammation that's highly localized in the back of the disc. And that's what your brain feels as sharp pain. And that's why people come, because that pain is so bad. Believe it or not, there's a lot of pain in the human body that is not sharp pain. There are two types of pain fibers. They are called visceral afferents and somatic afferents. And visceral afferents are pretty much fibers that you find in the viscera, like the intestines and stuff like that, where you get a kind of a dull ache, a dull pain. And then you've got what are called somatic afferent fibers, which give you a sharp localized pain. And the only difference between the fibers at the end there in the tissue is the fact that the somatic afferent fibers, SA fibers, travel to a specific place in the brain called the sensory homunculus. It's the first gyrus in the parietal lobe, and that gyrus is responsible for assigning a location on the body to that pain signal. And guess what? Everything that goes to that gyrus is highly localized pain. I mean, if it's pain, right? If it's light touch, then that's a different story. But if it's pain, it goes to that gyrus, and you can feel it, really, right where it hurts, like the lower back, for example. Whereas if you have pain coming from an intestine, you get this diffuse pain until the intestine starts to spasm, and then you get the really bad pain because of the spasms. Then those are affecting the somatic afferents again. So it's nothing to do with the actual structural part of the nerve fiber that determines if it's sharp pain or dull pain, poorly localized pain. It really has to do with where it goes in the brain. I think this scope needs to be worked on. I got a nice view when I'm in the middle, but as soon as I go to the side, as soon as I move it a little bit, we lose focus. I think that's the fibers, the glue between the fiber optic fibers. So I don't know if it can be repaired. It's not terrible, but it's starting to become an issue. Does that make sense?
Yes, sir.
And I don't know if they can fix fiber optic scopes where you've been sending them.
Yeah.
They can? You want to give it a try?
Yeah, definitely.
Have they fixed a cervical scope before?
Yes, sir.
Is this one that they fixed?
I need to check my notes.
Yeah. Check your notes, because if they fix this, then they didn't fix it. So we need to either have them redo it, or we need to send it to Wolf. So we're just going back and forth, working on this herniated disc. And the blue stuff, by the way, stains degenerated disc material, nucleus, not the annulus, just the nucleus. So Flynn, your job is to remind Luis, okay? About this scope. All right, there's more of the herniation. What questions does our audience have?
We have no questions, but we do have a couple congratulations for the patient that's getting the surgery.
Oh, good. That's so awesome. It's nice to have people cheering you on. Yeah, this is a nice man, nice guy, and you know, I'm so happy that he found us, and we're going to be able to help him get out of pain. Oh, by the way, in case you're wondering, this surgery is done outpatient. These patients all go home the same day. Our first surgery is outpatient. The cervical laser, we did 3 levels. He's going to go home soon. And this patient is outpatient as well. Everybody goes home. By the way, over there at 9 o'clock, you can kind of make it out, that flat thing. It's pinkish. That is the end plate. End plate is the surface of the vertebral body, right where the disc is. You can see that end plate down there. Very common to see when you're working on inside a disc. You just got to know what you're dealing with. See, it's like a pinkish color to the left there at pretty much 9 o'clock now. That's the end plate. There's nothing wrong with the end plate. We're not going to mess with the end plate. We're only fixing this annular tear and the herniation. We don't mess with the bone. So what I'm doing is I'm gradually pulling back. I'm gradually pulling the tube out as I move towards the periphery. But I can see this disc is definitely damaged. It's very scarred up, and the blue stuff is degenerated nucleus. And I apologize for the blurriness, temporary blurriness, but it's a little bit out of my control right now. You can see the laser just vaporizes all this. Once again, you're watching a thoracic T7-8 disc herniation be repaired with the Deuk laser disc repair at Deuk Spine Institute. It's November 4th, 2021. This is our 12th thoracic, I think, 12th or 13th thoracic surgery, thoracic laser surgery. And every one of our patients has had 100% relief of their pain that we've done. And one of them is on this broadcast. I didn't even know they were coming, but I'm so happy they're here. We need to spread the word, because it's sad when your life is just consumed with pain that you can't get rid of and nobody has an answer for you. You know? That's no way to live. These are fixable problems now. You know? There's no reason why people should live with this. Sometimes I feel like we live in a third world country in America here, because you have diseases like malaria, cholera, that kill people and destroy their lives in third world countries, even today in 2021, because they don't have access to clean water. They don't have access to the resources needed to fix the problem. And these patients around the United States don't have access to this technology. So it's like having cholera and, you know, suffering with cholera and dying from cholera, even though the cure is literally available. in this country, but people just don't know about it. That's why we have to change that. You know, and it's sad that people like Mark Zuckerberg or any of the social media giants don't take a more active interest in helping to disseminate knowledge and fact, scientific advances, for example, to ease people's suffering. They're too focused on profits and greed and not the human condition and human suffering. That's why I have to do these broadcasts, because nobody else is going to do it. You know, we could pay Facebook, we could pay Google, but I don't think it's right to have to pay to help people understand the truth. It's different, you know, when you're competing for the same, with the same product and everyone else has it, then you want to compete and market yourself. But when you're talking about a treatment that is not done anywhere else and people don't even know it exists, there should be a little more support from the billionaires club. All right, he's awake. I think he may be, but we are getting to the more painful area, so I would just keep an eye on it. We're almost done, but we need about 5 minutes left. You can see how big the tear is, by the way. Huge tear. The blue line tells you where the tear is. Literally, I just need 5 more minutes, but this is going to be the more painful part of the tear for him. This is where the somatic afferent fibers are all clustered at the periphery of the disc. The good news is I think when he's awake, this pain will be gone. Now, he does have another disc that needs to be fixed, but he's going to get that done at another time. And that's fine, you know.
We have a question from Reddit.
Yeah.
All right, well, so we have a patient who just got shots in their lumbar L5-S1, and they have been awake every night till 3 a.m., and they cry themselves to sleep. They want to know if you have any advice for them.
When was your shot?
It was last week.
Yeah, and it was a steroid.
I believe so, yes.
Yeah. Just so you know, steroids will keep you awake. Steroids cause like psychosis in some people. They react worse, and they will stimulate you and keep you awake. So I think part of your problem is obviously the fact you're staying awake because of the steroids. The other part is you obviously still have pain, right? And that needs to be addressed. So my best advice to you is send us your MRI, let me look at it, and I will tell you exactly what needs to be done to get rid of your pain. That's what we do here. We do it for free. No obligation, no money. It's free. Free service. So, yeah, but just be aware, everybody, steroids will cause difficulty sleeping because they affect your brain. They actually can cause a lot of problems like irritability, anxiety. Okay, just about done here. 1 minute. There's fat in the foramen, so we are out of the disc. That is the foramen. We're done. Beautiful. Scope off. We're going to put a little antiseptic called betadine. We've never had an infection with the Deuk laser disc repair. 15 years of surgery, not a single infection. Yeah, I need the irrigation. Just relax, you're doing great. We're almost done. All right, check it out. You guys see this, Diego?
Yes, we see it.
Done. We did the whole surgery through this little tube. Let's show you the incision. I'm just going to apply pressure for a minute in case there's a little muscle Blood, a little ooze, but I don't think there is. I'm going to let Luis move everything here. I'm going to give you a nice view. We're all done. There's the incision. You all see that?
Yes, we see it.
4 millimeters. Forget about ICUs. Forget about the hospitals. Forget about open surgery and painkillers. All this is done with Tylenol. No hospital. Amazing. Truly revolutionary. Ask any spine surgeon to watch this video. Their jaw will hit the ground. All right, type up your questions and I'll come answer them for you. Thank you.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Deuk laser disc repair. This MRI represents a typical case with L45 and L5S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, 2 patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. To accommodate the fusion hardware, a large bone grabber is used to perform a laminectomy by removing bone from the spine. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large pedicle screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before released to go home. The fusion screws are inserted into the bone, as shown in the X-ray. After all screws are in place, rods are used to connect the screws together to prevent movement of the secured vertebrae. Cross links are added to bridge the rods together for additional stability. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. Prior to closing the wound, a temporary drain is installed to allow excess fluid to drain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's 1/2-inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved.
Hi there. Am I on? Dr. Deukmedjian here with Deuk Spine Institute, and we just finished a spine surgery on a young man who really had kind of an unusual disc herniation, to be honest, just based on what we call probability. And probability is the likelihood of something happening. And, you know, when you look at the spine, it's not a real spine, by the way. This would be a very short person. We don't have any pygmies here. I hope that doesn't get me in trouble. Mini-me. This is mini-me spine. And I'm fat bastard, by the way. All right. So when you look at a spine from the top to the bottom, there's really 4 zones, but for all intents and purposes, no one cares about the tailbone that much because not much happens at the tailbone. But all the problems people get happen in the discs and joints from the cervical region, which is the neck, and then down here in the lumbar. I would say 3/4 of my patients, anywhere between 2/3 and 3/4 of my patients have disc problems in the lower back. Herniations, bulging disc, spinal stenosis, degenerative disc, you name it. And then the other 1/3 to 1/4 have problems with discs in the neck. All right, cervical spine. And very rarely do people have problems with the discs in the thoracic spine. But this patient did. And if his problem was a herniated disc between the number 7 and the number 8 thoracic bones. Now, what you're not seeing on this picture, on this model here, is the ribs. And the ribs come out and wrap around, and we don't have them here. We didn't pay for the rib model. We didn't pay for the McRib. But you can actually see how I did the surgery if you look here. We came from the back. I always got in trouble as a kid for telling jokes. Like the teachers never liked it. So let's just say this is where the problem was right there. I came from the back. I touched the facet joint just so I stayed medial. I didn't want to come over here because that's a no man's land and no woman's land and no LGBTA land and, you know, everything else that goes along with it, right? I mean, I'll just say no person's land. This is no person's land over here. So you want to hug the facet. You want to get into that disc injury right in the back here, right where the tear is. And that's what I did. And I used the x-ray machine to check my AP and lateral views. And I got in. Then I brought my guide wire down. Then I brought my dilator and tube. So I was literally operating right in this area here. Okay? And the lungs were over here. And we stayed away from them. We stayed away from the aorta and the veins and the lungs and all the bad things you want to avoid. I made the surgery look relatively easy, but please do not try this in your garage at home. It's not a good idea. I have literally the very best equipment in the world, millions and millions of dollars worth of equipment, and the best staff, trained staff who know what they're doing. And you know, we look like we just kind of do a spine circus going on here sometimes, but the reality is that the precision and detail of everything we do with the patients is monumental, and it is not trifle. It is one of those levels of detail that, you know, you just can't get in a garage or the back of a pickup truck. So it takes special medications, special equipment, special supplies like needles, syringes, that kind of stuff. If you look at the needle, for example, it actually has a beveled surface at the tip, and that beveled surface actually lets me navigate this way, or this way. You know, I can change the beveled surface so I can move in a certain direction by a millimeter or a degree. And so even to the detail of the needles we're using, it's not just a regular needle. It is a very special needle. So these are all details we leave out because they're kind of boring details, but there's a lot that's gone into every little detail and supply we have, which makes the surgeries look easy, but they're not that easy to do. So please don't think watching my surgeries allows you to go out and do them. You need to be trained. And I do train surgeons to do this. However, there's not a lot of surgeons that want to come and spend a year training with me to do these surgeries, which is about how much time it would take. So that's why there's not a lot of surgeons that do the endoscopic procedures. There's not a lot of doctors training them, and they don't want to spend the time to do it. It's really that simple. All right, what questions do we have?
We have a long one. So we have a person on YouTube. He's asking about his 57-year-old wife who was a registered nurse but had to give it up because she had mid-back pain. They got an MRI, says a small disc bulge at T7-8. Doctors say it's too small to warrant surgery, but the pain continues. Went to an orthopedic doctor and said that laser spine surgery is considered experimental and that hospital insurance most likely will not pay for it, but will offer her pain meds. She's tried injections. And
this is a long question. We need to break this down.
Okay, go ahead.
We're covering a lot of ground here, and and a lot of important topics. This is a great question and a great thank you for sharing. First of all, so I'm gonna keep going through the question, but I want to take it piece by piece because there's a lot we can learn from this. So the first paragraph or a couple of sentences said, "I have my wife who's a registered nurse." So this is a nurse in a hospital because the hospital insurance, they work in the hospital. So these are a very intelligent, well-trained individual in healthcare who works at a hospital. And so she's suffering with a herniated disc at what, T5-6? T5-6, right? Small herniation, just like this patient that we just saw. And there's no one that can help her. And the worst thing that's happening, besides she's living in pain unnecessarily, is that they want to treat it with pain meds. My God, folks, wake the fuck up. Pain meds? That's how we got in trouble with all the heroin addicts that are on the street right now. because doctors just wrote pain meds, Oxycontin, Oxycontin, Oxycontin for pain. This pain is fixable. It's curable. When I started practicing here in Florida, when I got done with my residency in neurosurgery at UF in Gainesville, I started practicing in 2004. In 2004, the number of prescription narcotic deaths in Florida was 7 a day. That's 7 people every single day, 365 dying in Florida from doctor-prescribed pain pills. Why do people die from doctor-prescribed pain pills? Because they overdose and stop breathing. They stop breathing. So we've had this massive, uprising nationally about the opioid crisis with painkillers shouldn't be prescribed by doctors. Now, I'll refrain from cussing because some people are sensitive, but I'm so angry. Now these insurance companies, politicians, board of medicines, they don't want us writing any pain meds for patients. We can give them, I think, 3 days and maybe 5 days max. That means every 5 days a patient has to come in and see the doctor for their pain, okay? That's ridiculous. How can you leave your job, your life, every 5 days to get a refill on pain meds? It's stupid. The most important thing is we're not fixing the pain. We need to start identifying the source and curing it with surgeries like the Deuk laser disc repair. We don't use narcotics. Patients do the surgery and have Tylenol or an anti-inflammatory, that's it. You don't die from taking Tylenol unless you overdose, all right? More than 4 grams a day. Yeah, it'll destroy your liver. But I'm just talking about regular Tylenol. You don't die from it. You don't die from ibuprofen and Motrin from overdosing. You don't stop breathing, okay, like you do with narcotics and opioids. So this poor nurse is being told by her hospital insurance doctors, an orthopedic surgeon, just take pain pills, Like, yeah, you could do nursing and take pain pills, right? No, because what if these narcotic pain pills do? They actually mess with your brain, and you don't do your job right. I'm going to tell you a quick story. I did surgery on a man, a professional who was a brilliant man from California. And he was not a CPA, he was an accountant type, okay? And he was for a corporation. And he was basically the guy that the corporation goes to get out of paying taxes, all right? So he knew the tax code left and right. He made lots of money working for really rich people to save them from paying taxes. That was his job. Like when you're an accountant and you have that job, you've reached the top. So this guy was brilliant. He had a fusion done on his lower back. I did the fusion. He came to me for the fusion because of my reputation. I did the fusion. I put him on Dilaudid. It's a narcotic, opioid, okay? But he was traveling from California here, so I went to visit him. He was staying with friends after surgery. So I did a surgery, discharged him the next day, and he was staying with friends at their house. But I knew where the house was. I went there to check on him, see how he's doing, make sure he's okay. I got to the house, rang the doorbell. Now remember, he's on Dilaudid. It's a narcotic, okay, painkiller. Same thing everybody else is prescribed like the nurse. The door opens. It's the people that he's staying with. I introduce myself. I'm Dr. Deukmedjian. I'd like to see, David, okay? And they said, oh, yeah, we'll go get David. So come on in, doctor. I sat on the couch in the living room, and David came around the corner, except David was naked. Naked. Everything was naked except for tighty whities. And he's standing in the living room of this house with really strangers around him, standing there with his tighty whities and nothing else. And being a doctor, I'm like, okay, that's cool. It doesn't bother me. I've seen people naked before. But I mean, what about these people he's staying with, right? What are they thinking? But maybe he knows them better than I thought, right? So it's cool, right? I'm fine with it. So I went there every day to check on him for about a week. And every day he was wearing nothing but underwear and a wife beater, And a few years later, I went to San Diego to visit my mom, and I met up with David, and he was doing well. And I said to him, do you remember your surgery and recovery? He goes, no, I don't remember any of it. The narcotics, I don't remember any of it. The pain pills, I don't remember any of it. That week, I don't remember. I said, do you remember that you would come out of your room in your friend's house naked except for your underwear? He said, that did not happen. And I said, oh yeah, that happened. And he said, I would never do that. This is a man who's normally in a suit and tie every day. And he was in his underwear. And he goes, don't screw with me. That would never happen. And I'm like, yeah, well, sorry. So that gives you an idea of the powerful effect that prescription painkillers have on people's brains. It messes with their thinking and their rationalization. So imagine a nurse who's taking care of sick people and has to like measure the amount of drugs she's giving them before she gives them a shot. I mean, I'll tell you another story. When I started as a neurosurgeon, I did a big spine fusion in the back of someone's neck at the hospital. And the nurse came in, and I had written for something called Valium. Valium is like a narcotic, but it's a benzodiazepine. Same kind of problems. It makes you stop breathing if you get too much. I wrote for 10 milligrams of Valium as needed for muscle spasms in the back of the neck. So I came in the morning to see my patients after surgery, and the whole floor was in people everywhere. I'm like, what's going on? They said a patient coded. I go, oh my God, patients code all the time in the hospital, they die. It's serious stuff, but that's terrible. I'm like, well, where's my patient? Oh, they're in room 310. I'm like, but that's where all the people are. They're like, yeah, it was your patient that coded. I'm like, what? First of all, nobody called me. So I found out what happened. The nurse gave the patient 10 milligrams of Valium IV push. It takes about 2 milligrams probably to kill you. She gave 10. It was supposed to be an oral pill. It was written as an oral pill, but the nurse screwed up. Now, I've wondered to this day, did this nurse have something she was taking maybe for her own pain? She was a bit older. Maybe she was on a narcotic herself. Anyway, point is, imagine if you're an engineer for NASA, you're designing the next rocket for the space shuttle. Do you want to be taking narcotic painkillers and doing complex algebraic equations in engineering? No. So this nurse we're talking about in this question, she's working with patients, measuring drugs, medications. I mean, you can't just take painkillers and do that job. You can't even drive a car when you're on painkillers. How are you supposed to take care of patients? So I'm really burning up right now about this situation. Let's keep reading and see what else is being said.
Second part of the question, right? So she's tried injections and she even had surgery where they deflated her right lung and froze her nerve along the rib. It worked for a couple months, but now the pain has come back. Finally, they ask, how difficult is it for insurance carrier to cover this treatment?
Yeah, great question. So the question went on to say that the patient, the nurse who's had this herniated disc at T7-8,
Yes,
had a needle procedure done, and somehow the lung was deflated, which I don't understand that. Maybe they accidentally poked the lung and deflated it accidentally, and then she had to have a chest tube, or maybe it was done intentionally, I'm not sure. But in the end, the Deuk laser disc repair, the surgery we just did, is the best surgery for this problem. And how hard is it to get insurance to cover it? If you have Medicare right now, it won't cover it. You have to pay out of pocket, cash. If you have commercial insurance, we will fight your insurance company, and we will use the best lawyers that we can get to do the fighting with your insurance company. They specialize in that. And we will do our best to get it paid for after the surgery. So that's all I can tell you. Insurance companies can be forced to pay for procedures that are medically necessary, but it's a battle because they don't want to pay for you to get out of pain. It's expensive, and they'd rather keep that money in their bank account. Next question. That was all. That was a long one, but a good one. So as you can see, I'm passionate about good patient care. It makes me angry when I hear stories about people who are suffering with treatable and fixable conditions that are being denied access to the best care. I'm a big believer that everyone should have access, everyone, regardless of your, socioeconomic status, your political views. Everyone here in the United States and even worldwide should have the ability to get out of pain, okay? And we can do that now. We just need the cooperation of the masses, the cooperation of the politicians, the cooperation of the insurance companies, and the cooperation of doctors. Doctors need to stop trying to treat patients they can't treat. You don't see me doing treatments here of things that like boob jobs, right? Am I doing boob jobs? No. Why? Yeah, boob jobs pay a lot of money. I would love to get that money, right? Who doesn't want money? But I'm not the right doc to do a boob job. I'd mess it up. I would be a disservice to the patient, and that wouldn't be helping anybody. So doctors need to learn their limits. There's an old saying, a man's got to know his limits, a woman's got to know her limits, and then I won't say the other things, but let's just say a person's got to know their limits nowadays. And knowing your limit means knowing when to send your patient to someone else who can fix them. So that's all I can say on the subject. Thanks for watching. We have 3 more surgeries coming up. The next one will be a lumbar laser, and then another lumbar laser, and then another lumbar laser. So go take your coffee break, get some popcorn.